West Nile forecasting. We use similar methods to weather forecasting, but apply that to infectious disease to hopefully inform public health departments to have more better timing for spraying and making better public health decisions, which is sort of seen within this photo where people are protesting around spraying. So as we know, climate change is here. Over the last 120 years, this map shows changes in what the average temperature was. Certain areas of the country have gotten cooler, like the Southeast, but other areas have gotten warmer, like the Northeast. And as we look at the Northeast, and in the area right around New York City, it's grown by greater than 2 degrees C. That's mostly been during the winter time, where temperatures have increased to being greater than freezing. So vector-borne diseases that used to deal with these much harsher winters now have lighter winters and are not dying off the same way. And so as we look at vector-borne diseases in the Northeast, there's two that really come to mind, which are Lyme disease and West Nile virus, which is what we'll focus on with this talk. Lyme disease was discovered in Connecticut, in Old Lyme, and West Nile came to the US in 1999 in Long Island. In addition to that, we also have other vectors that are moving north, as we see with these warmer temperatures. The Amblyomma americanum, the Lone Star tick, is moving north, which is bringing new potential pathogens with it. Starry, the southern tick-associated rash illness, presents similar symptoms to Lyme disease, but we don't really know what causes it. So treatment may be slightly different. In addition, they transmit heartland disease or ehrlichiosis. So these are new pathogens that haven't been in the Northeast, but could potentially emerge. Additionally, another one that was of interest and probably caught yourself in the news was Eastern equine encephalitis virus, which had a large outbreak in 2019. We saw a similar number of cases within the Northeast in 2019 as we've seen over the last decade. This was due to a really wet spring, which allowed for the Culistina melanura mosquito, which is a swamp mosquito, to be very prevalent and amplify the virus within that interaction between birds and mosquitoes. And then we had spillover events. And so we saw a lot of cases of that. And then another concern that we always have within the Northeast is travel-related cases of potentially dengue, chikungunya, or Zika, which are brought up from the tropics. And there are vectors in the Northeast that can transmit that. The Aedes albopictus is found in the Northeast at the lower portion of it. And this tends to feed on multiple hosts, not just humans, but other mammals. And so it's not a great vector for it, but it's competent to transmit it. And then, as earlier mentioned, the Aedes aegypti, where if it does become warmer and can move farther north, we could potentially have these outbreaks. And that's due to the fact that humans are the host reservoir for this disease. So it's transmitted between mosquito and human and is of potential concern. This is different than most of the vector-borne diseases that we deal with in the US, which have animal hosts. So Lyme disease, which is a tick-borne disease, has a multi-year cycle. It's 2 years, but there's actually one portion of that season that really becomes of concern, and that's during the time period where the tick is a nymph, where it's able to pick up the pathogen, the bacteria, in its first feeding stage, and then it's still very, very small, so it's of concern. And when it bites people, so we don't recognize it, and so really, late spring, early summer, we need to be careful about that. As you can see within this claims data, it's sort of that May, June, July that we tend to have the majority of cases. And now moving on to the other vector-borne disease in the area, West Nile virus. So West Nile virus first came to the US in 1999, caused a panic, then moved down the eastern seaboard, and then moved west. 2002 was the largest neuroinvasive disease outbreak ever recorded in the US, followed by 3 and 4, which were also very large. Then it sort of dwindled down in 2008, 2009, 10, 11. And then we had the second largest outbreak ever in 2012, showing how inconsistent from year to year and spatially it is that we see these outbreaks. So it's a great concern and has really changed the vector-borne disease pathway within the US, this outbreak. And so it's actually has a very complex disease transmission cycle between mosquitoes and birds, and then we have these incidental spillover events to humans. And this transmission cycle is influenced by the environment. There's multiple different meteorological conditions that will influence how the how often a mosquito will feed. So in higher humidity, mosquitoes are more host-seeking, so they end up looking for blood meal. However, if the humidity drops too much, the mosquito potentially will dry out and die. And then hydrology is also quite complex because it needs water to emerge, but if there's too much water, too much rain, heavy rains will potentially flush these breeding sites. Or on the flip side, drought may actually increase the mosquito population because predators are diminished. So dragonflies die out, and so you could have more larvae that emerge that way. It also potentially pushes mosquitoes and birds into closer quarters where we have greater amplification of the virus. So these dynamics are quite complex. And then as we think about temperature, temperature is a large driver, and it determines how quickly these mosquitoes will develop and emerge. And then on top of that, it will determine how much time in between blood meals a mosquito will have. It will determine how quickly the virus will replicate within the mosquito and is able to be transmitted. However, the warmer it is, the likelihood that a mosquito will survive to the next day is diminished. So all these things don't go linear together, and it's quite complex. But as we did some work throughout the US, looking at different environmental factors that may influence the disease transmission, we ended up settling on the extrinsic incubation period. And so what we did is we took 12 different areas across the US, and we developed these climatologies, which are shown in these blue lines. And then on top of that, we have these red lines, which represent the extrinsic incubation period. This is the threshold where if the temperature is above this, the virus will develop within the mosquito. If it's below it, it won't. So when we overlay information from trapped mosquitoes that are out there and viral activity, as you can see, the viral activity falls within this window that's associated with the climatology when it's above it. And then as we also look at human cases for that, we see that the climatology falls within that window that's associated with it. So we were able to use this extrinsic incubation temperature forcing to improve our forecast model, which was nice. And so as we think about these diseases, how do we prevent them? So there is no human vaccine or specific treatment for West Nile, but we can use personal protection such as mosquito repellent and long sleeve shirts and pants to prevent ourselves from being bit. In addition to that, we have these community-based mosquito control programs that go out and they spray. But they need to determine where to spray and when to spray. So one thing that they do is they go through and they set all these mosquito traps. They bring these mosquitoes back to the lab, sort through them by species because different species will transmit the disease differently. And then they run tests to determine which ones are present and absent for the virus. And then in addition to that, they use sort of high resolution satellite data. This is an image from EcoStress, which is able to take images at 70-meter resolution to determine the hydrology of the area. And this provides them with areas that are primed for breeding for mosquitoes or not, or potential amplification for the virus. And then they use that along with their trap data to determine where to spray. In addition to where to spray, there's also when to spray. And that's where these forecast systems come into play. We developed a forecast system that's very, very similar to a weather forecast, and it requires 3 components. The first component is we need surveillance data. And the surveillance data consists of mosquito monitoring to determine the infection rate of the mosquito at a given time. Additionally, we need reported cases of human illness. So we have those two data streams that we use. And then on top of that, we developed a mathematical model that describes sort of this interaction between mosquitoes, birds, and humans. And then we use a data assimilation method. This is very similar to how weather forecasts work. They take images of what's going on in the current weather and combine that with their model. And we do that for infectious disease to update it and have it align with sort of those local outbreak dynamics. And so this is what a forecast will look like. With this, and so each week what we have is we have these observations that have been assimilated in, which are these orange X's that get brought in. And so that's data that we've assimilated in. And then these orange dots are future observations. So after we assimilate information in, we get these blue solid lines. And that's our posterior. And that's more aligned with the local dynamics. And then we're able to run our model forward through the rest of the time for a forecast. And so what we have here is we put credible intervals on how accurate we think that these are. And we also have targets that we'd like to hit. So having something within this green box is a target that we would have. That would mean that we're able to predict within plus or minus 25% of the peak magnitude of infected mosquitoes, within plus or minus 1 week of the peak timing of infected mosquitoes, and then also the total number of human cases that we might see over the season. And so as you can see here, we did a nice job and we were able to forecast forward. And we're able to accurately predict the total number of human cases within 9 weeks prior to the end of the outbreak and 11 weeks prior to the end of the season. And so we were able to do this quite well retrospectively. However, when we began to put this into operation in real time, it was much more challenging because we needed data to flow. So we were able to get mosquito information relatively quickly. However, we had challenges getting human data. Part of this has to do with different policies that are there. So within the city, or within Illinois or New York, they have a 7-day policy related to when, if they see a case, when they should report that information. However, the state of California has a 1-day policy where that information is supposed to flow a little bit quicker. And so when we looked at these two, we showed that we were actually able to forecast in real time in the state of California. However, we had some challenges in New York and Illinois, and that had to do with these reporting lags. So California, by 1 week after the onset date, we had 30% more information than what we did in New York or Illinois. And then on top of that, that was able to improve our forecast ability by about 10% during a critical window of transmission. So it's very important that physicians or medical personnel report these diseases right away. And so with that, in summary, meteorological conditions are important for transmission. So as we saw within 2019, we had different weather pattern, and we had much more rain, which caused a large outbreak of equine encephalitis, eastern equine encephalitis, where drought conditions tend to drive West Nile much more, which is what we saw a large outbreak in 2018 during that drought. So this warmer, cooler climate is going to influence these vectors that are potentially moving north, like the Lone Star tick, which will potentially bring new pathogens, such as the heartland virus or ehrlichiosis into the region. And then public health agencies, they do go out and they monitor for these vectors to hopefully prevent outbreaks from occurring. And so it's very critical in order to reduce these outbreaks, that information flows between medical personnel, the public health agencies, and vector-borne abatement districts. So with that, I'd like to acknowledge all the people that I've worked with, and time for questions.
Terrific. We do have some questions. So the first one is, you spoke about the different times of preventing these, Oh, yes. When in the calendar year should we begin educating our patients on prevention strategies related to Lyme disease and West Nile virus?
So Lyme disease, it's a multi-year cycle for the tick, but it's really critical during late spring, early summer, when the nymph emerges, which is still very small and hard to see, but can transmit the bacteria. It is not vertically transmitted, so in the larval stage it's not infected, but if it bites a white-footed mouse on its first blood meal, can pick up the pathogen and then transmit it on the second. Normally, then ticks will go underground and then reemerge in the fall, and those are adults. And those can transmit the disease, but you're more likely to see them on you, so that's not as critical of a period. But really, you should use DEET or Picardin during the late spring, early summer to prevent tick bites. For West Nile virus, it's much more dynamic because it deals with the mosquito, which has a much shorter lifespan. And so each year it's actually highly variable, but the majority of the time that we do see peak infection rates and spillover events is in August and September.
Okay, and you mentioned emergency threats from vector-borne disease. Is there anything we can do to prevent the spread of their habitats?
On a personal level, one thing that we can do is we can maintain our yards and make sure that there's not standing water. As a community, we could begin to invest more in infrastructure to make sure that sewer lines are running appropriately and we don't have standing water, which are breeding sites for these vectors.
And we have a question about preventing, or are the community spray programs, how do they relate to this whole idea? And
well, the community spray programs, they go out and when they see that there is a risk of potential transmission, they will go out and they'll act and they'll spray to prevent some of these outbreaks from occurring. Now, keep in mind, a case of West Nile ends up in neuroinvasive disease, which is very debilitating, and 10% of those cases end in death. So it's something that we would really like to avoid, and it's challenging. And so they go out and they'll spray to sort of prevent these events from occurring and hopefully diminish it.
And do we need to do anything to prevent the people in the areas from getting affected by the pesticides?
The exposure from pesticides, it's at these very, very low doses, and they tend to put pamphlets out, and so you should probably go inside for the 30 minutes that they spray, because you don't, but the exposure levels are very low. So, in terms of what's been said.
One question mentions a geographical area such as Cape Cod, Massachusetts, where they're now experiencing, I guess, greater vector-borne diseases. Is that something you're aware of?
Yeah, so Cape Cod was one of the areas last year that got hit with the triple E outbreak. And so it's sort of, each year is very different in terms of what the environmental conditions are that will potentially, are appropriate for different mosquitoes. So it's quite complex. But yeah, I mean, it's sort of, next year there might be less mosquitoes that are in the area. You never really know. It's highly dynamic.
And a follow-up question, in terms of monitoring the effects on mosquito populations from these aerial applications, do we figure out the results at some point on how well they did to prevent outbreaks?
If they are applied at appropriate timing, there have been a few studies within the Sacramento area that have shown that they've been very effective in reducing human case counts.
Okay, you're off the hot seat. So I'd like to ask Dr. Alan Just to join us at the podium.